Hello again. We're going to talk here about hypercholesterolemia. The USMLE loves to test this because it is so common. You will see in an outpatient setting, you're going to see plenty of patients that have high cholesterol. It's almost the rule rather than the exception that older patients have higher cholesterol. We tend to deal with this with statins as well as exercise. However, there are a variety of ways we can approach this uh, depending on the patient and their specific cholesterol panel. So, hypercholesterolemia, by definition, is simply the presence of high cholesterol levels of the blood. It's a broad term. Usually it refers to LDL, but it can refer to high levels of LDL or high levels of triglycerides. So elevated LDL is usually associated with an increase, well, it's always associated with an increased risk of coronary artery disease. It's also associated with an increased risk of peripheral artery disease. And the reason that this is also important is because we monitor cholesterol levels in everybody over the age of 20. So cholesterol screening is going to be a major part of preventative care because elevated cholesterol, elevated LDL is associated with coronary artery disease. Coronary artery disease is associated with MI. So we want to prevent this problem before it happens so that we can proximally prevent MI. Both diet and genetics are going to play a role in cholesterol levels. There are families that tend to run high cholesterol levels, so it's going to be really important when you get a history on any patient to see if that particular patient has family members who have had early coronary artery disease, early MIs. Of course, diet's going to play an important role too. The screening recommendations, this just recently changed in the last few years, and it's now recommended that we start screening at age 20, and we check every 5 years. So unless the patient has any abnormal results, so if you get a normal lipid panel, then you're just going to check every 5 years. So at age 20, then again at age 25, then again at 30. But of course, if the patient has abnormal results, we're going to monitor it a little more closely. But as far as what you should know, you start at age 20 and then screen every 5 years. As far as pediatrics, we actually will only screen children under the age of 20 if there is a history of premature coronary artery disease. And usually we don't pick up coronary artery disease unless the patient has MI. So the way you should ask this is there anybody in your family that had a heart attack at an early age? Or is there anybody in your family that has had a heart attack, and if so, what age? Now, if it's the kid's grandpa and he was 77, well, then that's not a premature CAD. But if it was the kid's uncle and he had it at age 48, then that's a family history of premature coronary artery disease. And in that case, pediatric screening may be appropriate. So family history of premature coronary artery disease is in anytime there's a family member that's a male less than 55 years or less than 65 years as a female. That should say less than. Sorry about that. Okay, and then anytime there's genetic disease in the family that's related to cholesterol. So the one you're going to see most often is familial hypercholesterolemia. And this can be passed down either as an autosomal dominant or autosomal recessive trait, and usually you'll see this in a child manifested as xanthomas, so these yellow sort of plaquey lesions on the skin. We're not going to talk about pediatric diseases in this section. But just be aware that it can be appropriate to screen children, but in most cases, we start screening at age 20 years, and it's every 5 years in normal patients. So what is the lipid panel? Well, we get LDL, VLDL, HDL, and triglycerides. And I'm not going to address VLDL here because LDL is the more important number. So LDL is low-density lipoprotein, and what that's explaining is the protein is low density relative to the lipids that it's carrying. So you have a protein that's carrying lipids, and the protein is low density relative to the lipid. So it's carrying a lot of lipids on it. So LDL levels are probably, actually, I mean, I really would say that they are the most important number on the panel. So higher LDL numbers are associated with coronary artery disease. And any of these things that I noted below, this is not an exclusive list, but any of these things can cause higher numbers of LDL. So familial hypercholesterolemia, which of course I just mentioned is genetic, a high-fat diet, liver disease, particularly obstructive liver diseases, so primary biliary sclerosis, primary sclerosing cholangitis, which is associated with Crohn's disease, ulcerative colitis, hyperthyroidism, nephrotic syndrome, diabetes mellitus, anabolic steroid use, thiazide diuretics, and oral contraceptives. Actually, I would associate a high LDL with any kind of thyroid disease. High-density lipoprotein is just the opposite of low-density lipoprotein. So high-density lipoprotein means that you have a high density of protein relative to the lipids. So what HDL is it's a scavenger. It can go through the arteries and it can pick up lipids that are deposited in the arteries. And that's a good thing because when you have lipids in the arteries, what progresses from there is an inflammatory response, and then you get the development of that plaque. So if you have higher levels of HDL or normal to higher levels of HDL, that's good because you have a protein that can go around and pick up those lipids that have been deposited by the LDL, and it can pick that up before you get an inflammatory response and before you develop a plaque. So if you have low numbers of HDL, that's associated with coronary artery disease as well, but not as much as the high numbers of LDL. If you have high LDL and high HDL, that's still a patient we're going to want to treat. So HDL, we want it to be high. Higher is better for HDL. But if you have lower numbers of HDL, then that is a concern, in addition to higher numbers of LDL. So we want high numbers of HDL and low numbers of LDL. That's what we want. Most of the things that raise the LDL levels will also lower the HDL levels. That makes sense because what does LDL do? It deposits lipids in the arteries, and HDL picks up the lipids in the arteries. So when you're depositing lipids from your LDL, you have to use your HDL to pick them back up. So the higher the LDL goes, the lower the HDL goes. Exercise will also tend to increase HDL. So if a patient has moderately low HDL, diet and exercise is a recommendation, and exercise will tend to increase the HDL. Triglycerides is free triglycerides in the blood. Higher numbers are associated with coronary artery disease. We prefer to have triglycerides less than 150 milligrams per deciliter. So the things that raise triglycerides are high-fat diet and high body weight. And I didn't mention, as far as HDL, we prefer to have that greater than 60 milligrams per deciliter. Now, as far as LDL, what levels we prefer to have that at, that depends on the patient. So we want to make sure that we're taking care of the patient's cardiac risk factors. Now, this is based on the Framingham study, which I'm not going to talk about in depth, but basically what it comes down to are that there are these 5 significant risk factors for developing cardiac disease. And the ones that you should remember are tobacco use, and this is basically smoking, clinical hypertension, so this is any patient that has been diagnosed with hypertension, whether they're on treatment or not, a low HDL level, family history of premature coronary artery disease, and then age, which is greater than 45 in a male and greater than 55 in a female. If any of these are a check mark by them, then you count that as a risk factor. And that's going to be important because the more risk factors you have, the lower we want to keep your LDL at. So 160 is generally the optimal LDL for a quote-unquote healthy patient. So that's a patient with 1 or fewer risk factors. So that could be a 50-year-old patient, a 50-year-old male in perfect health. So he doesn't have a family history of premature CAD, he's got a fine HDL, he doesn't have hypertension, and he doesn't smoke. Then he's got 1 risk factor. Or it could be a patient with simply low HDL. Or it could be a patient with simply hypertension. Or just a 27-year-old female who smokes. that would be one risk factor. If the patient has 1 or 0 risk factors, we want to keep their LDL at less than 160. If they have 2 or more of those risk factors, then we want to keep their LDL levels at less than or equal to 130. Now, when this changes is if they're diagnosed with a specific arterial disease. So if they have coronary artery disease, peripheral artery disease, abdominal aortic aneurysm, or if they have diabetes, then we want to keep their LDL levels less than 100. So even if they have none of these risk factors, if they have diabetes, their LDL level needs to stay below 100. If they have 2 of these 4 diseases, then we need to keep it below 70. They're in a very high risk category. So if they have any of these diseases, it really doesn't matter what their risk factors are. They're automatically going to be kept below 100 or below 70. So if they don't have any of these diseases, you base your level that you want to keep them at on their Framingham risk factors. If they do have these diseases, then you base it out of how many they have, either 1 or 2 or more. So what's important to remember for the USMLE and for real life is that you can't diagnose hyperlipidemia unless you have 2 lipid panels showing the abnormal results. So you aren't going to treat anybody or make any kind of diagnosis until you've got 2 lipid panels taken on 2 separate visits, so preferably a week or 2 apart. I don't know what the exact number is, but not taken on the same day, not taken a day apart, on 2 separate visits. 2 fasting lipid panels showing 2 abnormal results. Then you can diagnose hyperlipidemia. So if you have a patient whose results are abnormal, then you're going to want to schedule a follow-up test. This is just like hypertension. You can't diagnose hypertension just on an isolated high blood pressure reading. You have to have 2 results that are abnormal. So what we're going to keep in mind for therapy is that the patient has about 30 milligrams per deciliter, 30 LDL points of leeway. So if their LDL levels are higher than what they should be, but not more than 30 points higher than what they should be, the treatment is going to be diet and exercise. Anytime, though, that they're diagnosed more than 30 points over what they should be, then we're going to treat them with medical therapy, with anti-hyperlipidemics. So that's how you're going to be able to remember this. So remember that it's abnormal, if you have 1 or fewer risk factors, it's abnormal to have greater than 160 milligrams per deciliter. You're going to tell this patient they need to be on a low-fat diet and exercise as appropriate. But you're not going to start therapy until they're more than 190 milligrams per deciliter, so greater than 30 points above what's considered abnormal for them. And it just goes down the more severe their risk is. So if they have 2 or more risk factors, of course it's abnormal to be over 130, you start a low-fat diet, but then when it's 160 or more, you start the anti-hyperlipidemic therapy. With CAD, PAD, AAA, or DM, one of the 4, you start a low-fat diet at over 100, anti-hyperlipidemics at over 130, and then if you have 2 of those diseases, you start at more than 70, and hyperlipidemic therapy at more than 100. So all you should remember is the risk factors or the diagnoses and their associated levels at which you start low-fat diet therapy, and then anything that's more than 30 points above that, then you're going to start anti-hyperlipidemic therapy. Okay, so what are the anti-hyperlipidemics? These are our medical treatments, our pharmacological treatments for high cholesterol. So by far the most common you're going to see are the HMG-CoA reductase inhibitor, or the statins. And the reason you see these the most is that these are associated with increased survival. So we always, save for a few patients, namely liver disease and pregnant patients, we're always going to want to have patients on statins. And these primarily lower LDL, and these are pravastatin, fluvastatin, atorvastatin, and so forth. And the way they work is by reducing the biosynthesis of cholesterol. We also have the fibrates, gemfibrozil and fenofibrate, And what these do is they increase the production of lipoprotein lipase. And what lipoprotein lipase is it's an enzyme that breaks down triglycerides. So if you increase production of that, you're going to reduce your amount of triglycerides. Niacin is a B vitamin, and it increases HDL. Bile acid sequestrants like cholestyramine and cholestyramine and cholesevelam, these reduce the uptake of bile acids in the GI tract, and so they lower LDL, but they're not our first line of therapy. We're going to use HMG-CoA reductase inhibitors as our first line of therapy in most patients to lower LDL. And then Ezetemibe is an add-on therapy. We'll usually combine this with one of the statins, and this will help to lower LDL. So let's talk about each of these in a little more detail. So the HMG-CoA reductase inhibitors, these are generally the first choice of therapy in patients, particularly in patients where LDL is the problem, and usually LDL is the problem because that's what we're looking at primarily. If the patient simply has an elevated or a low HDL, that's not an indication for therapy. So if the patient has an elevated LDL, usually more than 30 above what would be considered abnormal, then we're going to want to start them on an HMG-CoA reductase inhibitor or a statin. And as far as knowing the biochemical mechanism for this drug, not important for step 2 and step 3, but just know that it reduces the biosynthesis of cholesterol by blocking the rate-limiting enzyme. And anytime you want to start a statin in a patient, you're going to get liver function tests before you start therapy. There are some physicians who don't do this, but for the USMLE, they're going to want you to know that liver function tests are important to have in any patient before you start therapy, because you want to see if there are any underlying problems in this patient. So, you could have a patient who has underlying liver disease due to alcoholism. You're going to want to make sure that you have liver function tests so you can detect any kind of abnormalities before you start HMG-CoA reductase inhibitors. When you have a patient on these statins, the major side effects are going to be musculoskeletal. What you're most commonly going to hear about is a general aches and pains, muscle pains, which can be reproduced on palpation. The more severe adverse effect is going to be rhabdomyolysis, and the reason that this is really, really bad is because this is a deadly disease. And so rhabdomyolysis tends to present with severe muscle pain, acute renal failure, and particularly we see rhabdomyolysis in patients where statins are combined with niacin or fibrates. We never want to combine statins with fibrates ever, and we want to avoid combining statins with niacin. So myalgia and rhabdomyolysis, remember, are associated with statins. You can see liver enzyme abnormalities simply due to the statins, so you may get a question that shows you a patient that's asymptomatic that has elevated AST and ALT, and they're asymptomatic, but you go through their med list and you see that they're on statins. You can generally attribute a mildly elevated AST and ALT to statin use. But if it's severe, then you're going to want to do more in-depth analysis of that. But you can see liver enzyme abnormalities that are otherwise asymptomatic with statin use. We want to make sure that we're monitoring their INRs if this is a patient that's on anticoagulant therapy. So if this patient's on Coumadin or warfarin, we're going to have to probably adjust their dose because HMG-CoA reductase inhibitors do interact with the cytochrome P450 enzyme. So make sure that you're monitoring their INR when you first start statin therapy. We don't ever use statins in patients with liver disease, as you've probably accumulated based on the fact that there are liver enzyme abnormality associations with this. And in the rare patient that's pregnant who's on HMG-CoA reductase inhibitors, we cease therapy in them when they're pregnant. So you definitely want to make sure that women who are pregnant or may become pregnant are aware that they cannot be on these statin drugs when they're on or when they're pregnant. So statins, HMG-CoA reductase inhibitors, it's the same thing. So you may hear it referred to as statins. More commonly on the USMLE, you'll hear it referred to by its pharmacologic name, which is HMG-CoA reductase inhibitor, but they're the same thing. Okay, fibrates. So what are fibrates? Fibrates, they are, if you remember back to step 1, what they do is they induce PPAR alpha, and PPAR alpha is an enzyme that increases the production, well, it's a spot on an enzyme that increases the production of lipoprotein lipase. Don't worry about that mechanism, just know that fibrates increase lipoprotein lipase. And look at that word, lipoprotein lipase. Lipase means it breaks down a lipid. And what's the lipid here? It's triglycerides. So we use fibrates when we want to treat high triglycerides. There are patients that you may get sometimes who just simply have elevated triglycerides. Their LDL levels are fine, their HDL levels are fine, but their triglyceride levels are severely abnormal. In these patients, we'll jump right to fibrates. We're not going to use statins because statins don't have as much of an effect on triglycerides. They lower triglycerides, but not as much as the fibrates. The fibrates are going to significantly lower your triglycerides. So in a patient who has simply elevated triglycerides, we're going to jump right to fibrates with them. Fibrates can actually mildly increase the LDL level, so we have to keep that in mind. But like I said, primarily we're going to use fibrates in patients who have only elevated high triglycerides. We don't ever want to use fibrates with statins. So a patient with hypertriglyceridemia, we're going to use fibrates. The adverse effects here are similar to what you get with the statins. So myalgias can happen with the fibrates, but primarily when we get the adverse effects, it's when you have a non-judicious physician who has combined fibrates with statins. So what happens is when you have fibrates combined with statins, it dramatically increases your risk for myalgias, but particularly rhabdomyolysis. So we do not want to use fibrates in any patient that are taking statins. Fibrates, like statins, are contraindicated in patients with liver or biliary disease, and like I said, don't combine fibrates with statins. So fibrates primarily used in patients with isolated hypertriglyceridemia. Niacin is a B vitamin. You can get this over the counter, and this is used primarily as an adjunct to raise the HDL level. So primarily niacin raises the HDL level, and the reason that that's good is because HDL is our scavenger, and when we increase the HDL level, it reduces our the amount of lipids that we have deposited in our arteries. So that will probably reduce mortality. So the problem with niacin is primarily patient compliance, and it causes adverse effects in a significant amount of patients when you have them on such a high dosage of niacin. So the dosage that you need to be on of niacin to actually raise the HDL level is such a high dosage that you tend to get these adverse effects in a large number of patients. And what these adverse effects are primarily skin related. So flushing and pruritus, what you'll get is patients who say that their face is red all the time, they're itchy. And another thing is that this can worsen gout. How? I don't know. But niacin can worsen gout. So usually you don't want to give niacin to a patient with gout. Niacin does not reduce mortality enough to where you want to use this on any patient that you possibly can. Patients who have gout, you tend to just not want to give them niacin. For the USMLE, it's a bad idea because it will worsen their gout much more than it will raise their HDL level. So we don't use niacin in patients with liver disease. Again, you can see kind of a pattern here. And then in severe peptic ulcer disease. And what my inclination is, I don't know this for sure, but I think that there's some kind of vasodilatory effect going on, which is causing the flushing of pruritus, which should also worsen the peptic ulcer disease. So we don't want to give niacin in patients with liver disease or in patients with peptic ulcer disease. And I would also say that it's a relative contraindication, but not an absolute contraindication, to use niacin in patients with gout. But you can use niacin if you remember to advise the patient that these adverse effects are possible. You can use niacin in patients that have a refractory low HDL level, if the patient consents to it. But what I would recommend in most patients who have a mildly decreased HDL is to advise them to do some kind of aerobic exercise. That tends to raise HDL level itself. Okay, so the bile acid sequestrant. So as you might remember from physiology, bile acids are secreted through the biliary tract and into the intestine, and then they're reabsorbed back up through the intestinal lumen. So you're going down through the ampulla and then back up through the intestinal lumen, and then it goes back into the biliary system. So you have kind of a recycling. What bile acid sequestrants do is that they bind the bile acids and they reduce the reuptake of bile acids back into the biliary system. And so that's helpful because when we reduce our biliary tract reuptake, or our biliary acid reuptake, when we lower our amount of bile acid in our biliary system, we have to reabsorb LDL into the liver and into the biliary tract. And so it reduces LDL because the biliary tract needs it. So you're kind of indirectly reducing LDL because you're making your biliary tract need LDL. And so that will help us lower LDL level in the blood. We're more concerned not about having LDL in our liver. That's not a big deal. We're more concerned about having cholesterol or LDL in our blood, because the problem with high LDL is that it causes coronary artery disease. So if we can get cholesterol into our liver rather than in our blood, that's a good thing, and that's exactly what bile acid sequestrants do. Now, bile acid sequestrants are special because they're not absorbed. And so the fact that they're not absorbed is somewhat useful because we can use these in patients with liver disease. So is it going to worsen their liver disease? Possibly, but not like the other ones. So if you have a patient with severe coronary artery disease and a high LDL level, and you really, really, really want to treat their LDL, then you can use bile acid sequestrants. That's going to be the medication of choice rather than the statins or L-switch. The problem is with bile acid sequestrants, because they're not absorbed, you're not absorbing these fats, and so what you're going to get is steatorrhea. And with steatorrhea comes bloating and GI upset. So remember that the adverse effects of bile acid sequestrants are GI upset. And this is going to be contraindicated in patients with severely elevated triglycerides. All right, and then ezetimibe is combined with a statin to augment LDL reduction. So you can use, so if you have a patient where you want to use a statin and you have the patient on a statin, but their LDL levels are still not where you want it to be, they're still higher than your target range, then you can add ezetimibe onto a statin, and that can augment your LDL reduction. And all ezetimibe does is it blocks the transporter of cholesterol in the intestine, so you're not absorbing cholesterol from your gut. And this is different from bile acid sequestrants. Bile acid sequestrants block the reuptake of bile acids. They actually bind the bile acids and block their reuptake. Ezetimibe blocks the transporter on the intestinal lumen, blocks the transporter of cholesterol, and so you're going to reduce the cholesterol absorption in the GI tract. Ezetimibe, by another mechanism, also increases the cellular absorption of cholesterol from the bloodstream. And like I said, we're more concerned with the cholesterol being in the blood, not the cholesterol in the body. So if we can increase the cellular absorption of cholesterol from the bloodstream, that's a good thing. And that's another thing ezetimibe does. So there's sort of two fronts where ezetimibe helps us lower our cholesterol in our blood. And the nice thing about ezetimibe is that there are very few adverse effects. It tends to be pretty well tolerated. Ezetimibe, though, is contraindicated in patients with severely elevated triglycerides. So some special considerations is that patients with severe liver disease, where we're going to primarily goal their treatment towards is reducing the risk factors. Just because liver disease, not only because most of these drugs tend to worsen their liver disease, but remember, most drugs are excreted through the liver. So any patient with liver disease, we don't want to have them on drugs if we don't have to. So reducing the risk factors, diet and exercise, that's going to be where we primarily target their treatment. But if we need to treat them with pharmacologic therapy, bile acid sequestrants are going to be where we target their therapy towards. With pregnant women, we don't use any anti-hyperlipidemic drug. So if a woman is pregnant, we stop her hyperlipidemics, or we stop her anti-hyperlipidemics, and diet and exercise are going to be mainstay. And of course, these women are going to need to be monitored for high cholesterol levels. But diet and exercise are plenty appropriate in pregnancy for any woman. So diet and exercise is the mainstay of therapy for pregnant women with high cholesterol. And we didn't give much attention here to pediatric patients, primarily because this is more of an adult problem. But in pediatric patients, and primarily I'm talking here about the kids with familial hypertriglyceridemia, when they're young, and by young I mean under the age of 8, you should use bile acid sequestrants and or fibrates. So this is from, I'm not a pediatrician, but I would say from a young age, infant, to whenever it's diagnosed, to age 8, you'll use bile acid sequestrants and fibrates. After they turn 8, you can start pravastatin, and the reason that we want to switch to statins is that they're more effective and they have fewer side effects. So at age 8, you can use pravastatin. That's particular, though. Pravastatin is approved at age 8 for pediatric patients. The other statins you can use after age 10. So these are just some special considerations.